Good evening, everybody, and welcome. My name is Roxanne Chabot from RBC Consultants. Thank you for joining us this evening for our webinar on skin barrier integrity and skin of color, what you need to know. As guest speaker this evening, we have Dr. Andrew Alexis. Dr. Alexis is Director of Skin of Color Center Chair, Department of Dermatology at Mount Sinai Morningside and Mount Sinai West, as well as Professor of Icahn School of Medicine at Mount Sinai. We also have Dr. Heather Woolery-Lloyd. Dr. Woolery-Lloyd is Director, Skin of Color Division, Dr. Philip Frost, Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine. We'd like to thank our sponsors, CeraVe, who have made this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using our telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you want to submit a question, just go to the right-hand side of your screen in the question chat pane and write your question in that area. I've written you a little note so you could see where you can type in your questions for Dr. Andrew Alexis and also Dr. Heather Woolery-Lloyd. At the end of this webinar, you will be receiving a survey. If you could please fill it in for us, we'd really appreciate it. Finally, within 1 to 2 days of this webinar, you're going to be receiving a recording as well as a certificate of attendance. Again, if you have any questions, please submit your questions using the question chat pane on the right-hand side of your screen. So without further ado, I will pass the floor virtually to Dr. Andrew Alexis.
Okay, well, thank you, Roxanne, and it's a pleasure to be here tonight to present on this very exciting topic of barrier dynamics and how they are relevant to skin of color. I'm going to begin with a brief overview of barrier function, and then we'll go into specifics about relevant differences in different racial ethnic populations. Okay. So when we talk about the epidermal barrier, of course, the epidermal barrier is our natural protection against water loss and prevents entry of bacteria and viruses and irritants and allergens into the skin. It's made up of the stratum corneum, which is a multicellular, vertically stacked layer of cells embedded within a hydrophobic extracellular matrix. And it's often referred to as the sort of the bricks and mortar model of barrier, where the bricks are the corneocytes and the mortar is made up of free fatty acids, cholesterol, and a number of different ceramides. And ceramides make up about 50% of the lipid content of the mortar in the stratum corneum. And then there's also natural moisturizing factor, which is made up of filaggrin breakdown products, and these are contained within the corneocytes and also contribute to barrier function. Now, any alterations in the lipid content or the overall composition of the stratum corneum contribute to defects in the barrier function that can correlate with increased water loss, transepidermal water loss across the barrier, and enhanced barrier permeability, which has important clinical implications. So, are there racial ethnic differences in barrier structure and function? And this is really the key question for tonight. And the answer is that yes, there are a number of studies that have identified differences between populations for a variety of different stratum corneum functions, including transepidermal water loss, water content, ceramide level, and skin reactivity. However, while it would be tempting to be able to take these studies and say that we can predict what an individual's skin responses or barrier function will be just based on their Fitzpatrick skin type or their racial ethnic background, unfortunately, it's just not that simple. We just don't have enough data to be able to jump to firm conclusions. But there are a number of studies that point to some important trends. So the limitations of the studies that we do have, as a caveat overarching everything that we're going to be talking about tonight, is that they're based on small sample sizes. They have varying methodologies, including varying anatomic sites where different things are measured, such as transepidermal water loss can differ, whether it's from the facial site or from a body site. And racial ethnic groups are not always consistently defined in these individual studies. Another limitation is that there's often a lack of standardization of skincare regimens, or a lack of description of what the skincare regimens were for subjects that entered into the study and were what they were told to do from a skincare perspective before measurements were taken. And of course, that could impact results. Now, all those caveats aside, there are some well-established differences that are in the literature between different populations. And most of these differences are between Black skin and white skin, and to a lesser extent, there's data comparing East Asian populations to other populations. Now, when we look at Black skin compared to white skin and stratum corneum characteristics, something that's been identified in a number of studies is that the stratum corneum thickness is relatively equal between the two populations. However, in Black skin, the stratum corneum has a greater number of cell layers, and therefore it takes more tape strippings to disrupt the barrier. So the cell layers are arranged more compactly, and there's equal thickness. Another difference that has been replicated in more than one study is the ceramide content in Black skin compared to white skin, which has been shown to be reduced. Now, pH, which I listed on the slide, has variable, there are variable results from different studies, so we won't talk about pH. But back to ceramides, where there are data that support consistent differences. This is a nice study that was conducted here in the New York area, a multi-ethnic population in the New York metropolitan area, consisting of three main groups: African Americans, Caucasians, and East Asians. And a number of different stratum corneum functions were looked at. And this looks specifically at ceramide content between the three groups. And what we see is that African Americans in this study had a significantly lower ceramide content in their stratum corneum compared to the other two groups, Caucasians and East Asians. Interestingly, similar findings with a different methodology, but similar conclusions were found from a completely different population. This is from Denmark. This is from Copenhagen, Denmark, where three groups, individuals of African ancestry, East Asian ancestry versus Danish ancestry, all residing in Copenhagen. They looked at their ceramide to cholesterol ratio in the stratum corneum, and again found that those of African ancestry had the lowest ceramide to cholesterol ratio in this study, and this was significantly different compared to the other groups. So this difference in ceramide content might contribute to the clinical observation of xerosis being a highly prevalent and often more severe phenomenon for our patients of African ancestry, not to mention it being more striking and more noticeable just visually because of the contrast between the dry, scaly areas and the background pigmentation. What about other stratum corneum functions? So back to that same New York-based study, this looked at the number of tape strippings to disrupt the barrier. So this is looking at barrier function. And interestingly, East Asians had were essentially the most sensitive, meaning that the least number of tape strippings were required to disrupt the epidermal barrier to get over a certain threshold of transepidermal water loss. And this was significantly lower than Caucasians and than African Americans. Previous studies have also shown this, so that phenomenon seems to replicate it. Another finding was that African American skin showed stronger stratum corneum cohesion, in that there was a higher protein concentration per tape stripping compared to the East Asian group. So taken together, when we look at the East Asian group, they had the weakest barrier properties, meaning required the fewest number of tape strippings to disrupt the barrier. And this might contribute to some of the increased skin sensitivity that has been reported in other studies pertaining to the East Asian populations. One often quoted study supporting a higher sensitivity in East Asians is this very, very small study. And despite it being so small, it tends to be the primary reference for most of this discussion. But in this study, sensitivity as measured by changes in transepidermal water loss and vasodilatation lag time, the East Asian population in this cohort demonstrated the greatest degree of sensitivity compared to Caucasians and black skin. Clearly, more studies are needed to better understand these differences. But based on these observed and reported differences, we have an idea that maybe there are structural and functional differences in different patient populations of different racial ethnic backgrounds that might contribute to the variations that we see in prevalence and severity and clinical presentation of disorders like atopic dermatitis and xerosis and pruritus. And these barrier differences might also contribute to some of the cultural impact of skin health and skin disease. As an example, the phenomenon of ashy skin among blacks or others of African ancestry, and the perception of skin sensitivity, greater skin sensitivity among many East Asian populations. So we'll talk about those in a little bit more detail. So let's start with eczema, atopic dermatitis, which epidemiologically has been found to be in numerous studies, has demonstrated a higher prevalence among black children, children of African ancestry, compared to white children in the United States. Another study coming to the same conclusion that African American children were 1.7 times more likely to have atopic dermatitis than their white counterparts. Outside the United States, there's also studies that support a greater prevalence, such as this study from the UK, where London-born black children had a higher prevalence of atopic dermatitis diagnosed by a dermatologist compared to white children residing and born in the same area in London, England. And these differences, it's important to note that these differences persisted after adjustment for potential confounding variables. Back to the United States and looking at the burden of atopic dermatitis between populations, this looks at at healthcare utilization data. How frequently is the diagnosis of atopic dermatitis made during visits? And among the Black or African American population in the study, there was a twofold higher visit per capita value of atopic dermatitis compared to whites, whereas for Asians and Pacific Islanders, 6-fold higher visits per capita where atopic dermatitis was diagnosed compared to whites. And this is not due to greater healthcare utilization by these groups. In fact, these same two populations have lower overall utilization of healthcare services for medical and skin conditions. So this is something specific to atopic dermatitis. We certainly see in the clinical setting a tendency to see patients of color present with very advanced stages of atopic dermatitis with great severity. And from a genetic standpoint, there are variations in some of the genetic risk factors for atopic dermatitis, specifically filaggrin, the most well-known genetic predisposing risk factor for atopic dermatitis. It turns out that when we look at different populations, that the filaggrin mutations are less relevant than they are in individuals of European ancestry with atopic dermatitis. So whereas filaggrin mutations are found in up to 50% of all European ancestry patients with atopic dermatitis, a much lower percentage, approximately 27% of Asians with atopic dermatitis have filaggrin mutations. In fact, when looking at specific ethnic and geographic populations within East Asia, we see differences in the specific filaggrin null mutations that are unique to their ethnic group. When we look at the African American or other populations of African ancestry, we see even lower associations between filaggrin mutations and atopic dermatitis. In this study, only 5.8% of Blacks, compared to almost 28% of whites, had at least one of the 4 most common filaggrin null mutations. So this suggests that there are other genetic factors that relate to barrier function that may be more relevant and more closely associated with atopic dermatitis in non-white racial ethnic populations. When it comes to xerosis in darker skin populations, there is the observation that it's may be more prevalent, more severe, presents more severely, and it's certainly more visually striking, as I alluded to earlier, with that contrast between the dry, scaly skin and the background of epidermal melanin. And then there's also a tendency to have follicular prominence in the context of cirrhosis and atopic dermatitis. When it comes to itch, there is emerging data that suggests racial ethnic differences in itch severity and itch prevalence. And it's possible that barrier differences contribute, at least in part, to some of these observed differences in pruritus and associated diseases like prurigo nodularis. From a cultural standpoint, dry skin and just the standard skincare practices do vary from one population to another. I think that one of the best examples is in populations of African ancestry with richly pigmented skin. Having dry skin is particularly, or dry or ashy appearing skin is particularly stigmatizing, and so it's culturally ingrained to moisturize the skin daily, much more so than in many other cultures. And so having moisturizers that prevent the appearance of dry, ashy skin is extremely high priority. And certainly when we look across the spectrum of cultures and populations, we see variations in what the cultural norms are for cleansing and moisturization. And all of this does play a role in the overall prevalence of cirrhosis and contributes to some of the clinical presentations, kind of some of the clinical aspects of atopic dermatitis and related conditions. And so when we make our recommendations for skincare, it's important to take into account what the cultural norms are within the patient population that the patient belongs to. So with that, it's my pleasure to turn things over to my colleague from University of Miami, Dr. Heather Woolery-Lloyd.
Thank you, Andrew. That was a wonderful talk. I am going to start. My first talk is, I'm going to start focusing on moisturizers and decoding the label. So I know that as clinicians, our patients ask us a lot of questions and we don't get as much training in this. So this is what I want to talk about first. So a brief overview, I'm going to define moisturizers first of all and talk about the types of moisturizers and go into physiologic lipids in moisturizers and then some common questions that I sometimes get from my patients, and I'm sure you all get them too. So when we look at moisturizers, there are very specific characteristics. Of course, they increase hydration of the stratum corneum. That is the primary goal of a moisturizer. They also stop water loss. That ideally a moisturizer would stop water loss. They make the skin feel smooth. They reduce itching, stinging, and burning by restoring the barrier. And ideally, a moisturizer is hypoallergenic, non-sensitizing, and non-comedogenic. So there are 3 types of moisturizers. I'm sure all of you are familiar with these terms, occlusive, humectants, and emollients, but I want to go into the definitions because sometimes it can get a little bit muddy. What's the difference between an occlusive, and humectant, and an emollient? So occlusives actually coat the stratum corneum. That's probably the easiest one. It's the most intuitive when you think of an occlusive. It coats the stratum corneum to decrease transepidermal water loss. And you can see here that an occlusive basically is like a thick barrier, that bright red barrier across the top of the stratum corneum so water doesn't escape. And it's really an artificial barrier on top of our stratum corneum. Next, the most common occlusive we're all familiar with is petrolatum. This tried and true has been around for, I don't know, hundreds of years, I'm sure. And the other occlusives that we're familiar with are mineral oil, lanolin, dimethicone is very popular, also used as an occlusive in hair care frequently, sunflower oil, evening primrose oil, olive oil, and jojoba oil. Now, humectants are quite different. They actually attract and bind water. So they can improve the stratum corneum because they're really pulling water in. So if you're in a humid climate like I am in sunny South Florida with 100% humidity almost all year, humectants are great because they pull water in and hydrate the stratum corneum that way. The only issue with humectants is that in very dry weather, they can actually draw water from surrounding cells and actually dry the skin further. So it's important that humectants are used in combination with an occlusive agent to kind of trap in the moisture. So some examples of humectants: glycerin, propylene glycol, urea, hyaluronic acid, heparin sulfate. All of these are humectants, and they work by binding and pulling water into the skin. Now, emollients are kind of between these three categories. This is the most amorphous. It's not as clear what an emollient is, but basically the goal of an emollient is to soften and smooth the skin by filling spaces between the skin flakes and creating a smooth surface. So typically, emollients are light, oily substances, and some emollients can function as occlusive moisturizers. So there can be an overlap. It can be an emollient and an occlusive at the same time. But in general, the primary goal of an emollient is to make the skin feel smooth. And in general, they're grouped by their ability to spread. So it's some examples of emollients: sesame seed oil, grapeseed oil. These are all light oils. And then also lipids, fatty acids, and ceramides. They are also emollients. So that kind of brings me right into the next part of my talk, which these are the physiological lipids in our skin, and we also find them in moisturizers. So ceramides, fatty acids, and cholesterol, as we heard from Dr. Alexis, are natural components of our skin. And ceramides are essential for skin barrier function. That's their #1 goal, is skin barrier function. And when we use them in moisturizers, they're used specifically to restore that barrier to our skin. So as Dr. Alexis mentioned, ceramides are the major lipid found in our skin. There's a ratio between free fatty acids, cholesterol, and ceramides. This is not static, but a general ratio. And ceramides are around 40 to 50% of the natural lipids in our skin. So fatty acids, these are typically, and when we see them in cosmetics, they come from plant oils. So linoleic acid comes from sunflower oil or safflower oil. Gamma linoleic acid is found in rosehip oil and evening primrose oil. Oleic acid is in olive oil. That's where I think it got its name, but also avocado oil and sweet almond oil. Stearic acid, which is a saturated fatty acid, and I'll talk about the significance of that. That's found in the butters like shea butter or cocoa butter. So what is the significance of a saturated fatty acid? They tend to be comedogenic. So for example, cocoa butter is comedogenic. So you would think about, you wouldn't want to necessarily use a saturated fatty acid, for example, in an acne-prone patient. Palmitic acid is another saturated fatty acid. It comes from palm oil, thus its name, palmitic acid. And then lauric acid arises from sodium lauryl lactylate, which is what we actually see on the label, but that's found in coconut oil and palm kernel oil. So cholesterol is the third one, the third lipid that we see in our skin. It has its moisturizing effects, as we know, and it's typically used in combination with fatty acids and ceramides for the best moisturizing effects. So I want to talk a little bit about MVE, which is multivesicular emulsion, which is a system to deliver moisture to the skin. So this is actually a multivesicular emulsion. It's a multi-phase oil and water emulsion system consisting of a series of concentric spheres. So oil and then water, then oil, and they're concentric. And this traps the ingredients in your moisturizer and delivers it more evenly to the skin. So all of us are familiar with this type of technology when it comes to, for example, retinoids. A lot of times we'll hear about very unique ways to deliver retinoids to the skin so you don't get hot spots and irritation from a retinoid. Well, moisturizers are similar. It's best, ideally, if we would deliver that moisture over a period of time, and this technology allows the product to do so. So the MVE system in CeraVe provides a slow and sustained release over time rather than a rapid burst of this ingredients for our moisturizer. So we always think of this in acne, but we never really think about this in our moisturizing products, and I think it's a good technology to use. So we'll go into common questions. Our patients love to ask us questions about skincare. And a common question I'll get from patients is, oh, this has cetyl alcohol or cetearyl alcohol. Is it drying? You know, how is that in a moisturizer? Well, actually, these alcohols are not drying. They are actually waxy alcohols. So the FDA has very strict labeling on their labeling requirements for companies who produce cosmetics. And you can't use certain terms unless you meet certain criteria. So interestingly, you can put alcohol-free on your label even if it contains these alcohols like cetyl alcohol and stearyl alcohol. The reason why is because these are not drying alcohols, they're waxy alcohols. So when patients ask you those questions, it's important to understand what makes these ingredients different. Now I want to jump into ceramides because really what's most, I think, interesting to us as clinicians is the clinical research. Let's look at the data on how ceramides actually work real life in our patients, and I'm going to review that data right now. So as Andrew mentioned, skin of color patients have increased perceived dry skin. So he talked about ashy skin and cultural concerns about ashy dry skin, and I definitely understand that. As a mother, you know, the worst thing you could possibly do as a Black mother is to have your children have ashy dry skin. So it was something that I completely understood in his lecture, and it is a real concern for people of African ancestry. But we also know clinically there's decreased ceramides. We saw the studies that Dr. Alexis presented, decreased ceramides in the stratum corneum, and of course, increased atopic dermatitis incidence and also severity. So atopic dermatitis is much more severe in Black children. So the question arises, you've heard all about the problems we have with ceramides in our skin of color patients. Can topically applied ceramides be incorporated into the stratum corneum, or do they kind of just sit on the skin surface and do nothing? So that is a key question as clinicians. What exactly is happening when our patients are using these moisturizers? Do they provide any physiologic benefit? And we're going to go into that in this study. So this is a beautiful study that was a single center split body study, investigator blinded, and it involved 53 healthy women, all Fitzpatrick skin types 1 through 6. They were 30 to 65 years old, and they either had very dry to dry skin, skin texture roughness, desquamation, dry scaliness, lack of radiance, and erythema on the lower legs. And the subjects that were given a washout period, so they're given a glycerin soap to use at home for 2 weeks, and then they were asked to come in, they were asked to actually shower in the morning and come in the afternoon. They weren't allowed to apply moisturizers to their skin for the afternoon visit, and they came to the clinic between 3 and 5 p.m. and then they were assessed for all of these things. So they were assessed for skin dryness, skin texture, roughness, tactile and visual, desquamation, luminosity, erythema, and the overall appearance of the skin. Then the subjects also gave a sensory assessment. So their subjective feeling, if their leg was itchy, was it stinging, was it burning? And they gave that assessment for each leg individually. And then they also did corneometry. Corneometry measures skin hydration, or the amount of water in the skin. And they did photos. And finally, they did something called desquame tape stripping. So we heard about that a little bit earlier tonight. But those of you who aren't familiar with this process, basically it's a process to measure lipids in the skin. So what you do is you apply a tape and you discard the first one, and then you take the next 2 subsequent tapes. You take that tape to the lab, and solvents are used to extract the lipids from this tape, and you can measure the amount of lipids in the stratum corneum using chromatography. So it's a very unique way to measure stratum corneum lipids in a kind of a non-invasive way with tape stripping. So the study product was CeraVe Moisturizing Cream, and on the first day, the baseline visit, they applied it to 1 randomized lower leg between the knee and the ankle in the office. And then they came back on days 3, week 4, and then 48 hours after week 4. And they were told to continue to apply this at home twice daily. And then on the evaluation days, the subjects were told to shower in the morning and come in without any of the study product applied, because obviously that wouldn't be helpful if you already had the ceramides topically applied to your skin. So on study visits, no product was applied. They came in after showering. So this slide shows you, and I'll use my mouse to show you, at baseline, this is the level of severity of dryness. And you can see at 4 weeks a significant drop in the level of severity of dryness and the level of severity of skin texture and roughness, flakiness, and erythema. What's also interesting on this slide is that at 48 hours after stopping, so the last visit was the 4-week visit, take the study product away from the patient, they go home, they get nothing to apply for 2 days, no moisturizer at all, just continue to use their soap and come in, and they came in 2 days later, and you still see that there was a reduction in skin dryness, roughness, flakiness, and erythema. They also, as I mentioned, looked at corneometry, which measures skin hydration. So at day 3, there was a 30.6% increase in water content in the skin. At week 4, there was a 38% increase in water content in the skin. And then even 48 hours after stopping the product, they were still maintained around a 21% increase in the water content in the skin. Now, subjectively, remember I mentioned that the subjects also had to rate itching, burning, and stinging. So this is actually at the baseline visit, and you can see here the itching immediately after applying reduced by 60%, the burning reduced by 55%, and the stinging reduced by 42% immediately after application. Now, this, I think, is some of the most interesting parts of this study, because this is looking at specifically what happens to the lipids in the stratum corneum after using a ceramide-based cream for 4 weeks. So here we'll start with cholesterol. You can see at baseline, this was the level of cholesterol in those tape strips that they took. And then you can see a 13% increase in cholesterol at week 4. And then after stopping the product for 2 days, you can still see that 48 hours after stopping use, the cholesterol level still remains around 7% above what it was in the skin at baseline. When you look at free fatty acids, you see again this 11% increase of free fatty acid in the stratum corneum of these subjects. And again, 48 hours after stopping the use, you'll still see that the levels remained 5% above baseline. And of course, what we're most interested in is what about ceramides? How did the ceramide content go up? And again, we see an 11% increase in ceramide content compared to baseline. And again, even 48 hours after stopping the use of the study drug, they had ceramide content remain 4% above baseline. So this study suggests that using topical creams does influence the actual physiologic lipids within our stratum corneum. Now, they did some photographs, and you can see at baseline that classic ichthyotic skin that we see in our patients who have dry, xerotic skin. You can see significant improvement here. This is 48 hours later, kind of starting to return back to that dry state. Again, at baseline here, week 4, and then 48 hours after stopping the treatment. Now, this is a very interesting study because the study we just discussed looked at a topical ceramide cream compared to no treatment. But how does a topical ceramide cream compare to a standard moisturizer that doesn't have ceramides? So this is a study that was presented, a poster that was presented, and I picked out the interesting piece because that was a lot of information on that slide. But I think what we're most interested to know, what I'm most interested to know, is how does a topical ceramide cream compare to a standard cream? And that's what this looks at. So you can see here, these are the lipids that were extracted via tape stripping. This blue line is the test cream, and the red line is the reference cream. And you can see with each tape strip number that there is more lipids in the test cream that contains ceramides compared to a standard cream. And the significance of this axis is that this is the increasing tape strip number. So you're getting deeper and deeper into the stratum corneum with each strip. So if you do, let's say 5 strips, this is how much ceramides, or how many lipids, these are overall lipids in this this group compared to this group. But you can see even all the way down deep into the stratum corneum that you still see more lipids in the ceramide-based cream versus the standard cream. So I think this is very interesting because it suggests that this particular study product was better than a standard moisturizer in restoring physiologic lipids. So in conclusion, we know that ceramide deficiencies have been observed in darker skinned individuals, and specifically Black patients compared to lighter skinned patients. We also know that clinical data demonstrates that a skincare regimen incorporating a ceramide containing moisturizer has been proven to increase lipid content, including ceramides in that stratum corneum. Those tape studies showed us that. So darker skinned individuals may benefit from using topical ceramide containing skin products. So now I'm going to hand the presentation over to Roxanne, who will move us into the questions, because I'm sure you have lots of questions.
So yes, we're going to move on to our question period. Now remember that you'll be receiving the recording of this webinar 1 to 2 days after the webinar, and you can always go and see the recording on cerave.com and rbcconsultants.com. Again, if you want to submit questions, please submit the questions in the question pane on the right-hand side of your screen. And again, we would like to thank our sponsors, CeraVe, for making this educational event possible. So we do have a couple of questions. In regards to the skin barrier, many skin of color patients with cirrhosis and severely dry skin scrub their skin with washcloths, which makes the problem worse. How do you address this with your patients?
Well, I can definitely answer that because I'm originally from the Caribbean, and it's very popular in that culture to use a washcloth and scrub the skin and when bathing. And I think that sometimes parents look at me with disgust if I tell them that we don't want to use the washcloth on their atopic dermatitis kids. You know, they think, oh, how horrendous, like in a blasphemy. But what I basically tell parents and patients who love to scrub, and for these patients, it makes atopic dermatitis so much worse. Use the washcloth in the private areas, the underarms and the groin, where you know, cleansing is much more important. But on the arms and the legs, a gentle soap cleanser is totally fine. And it will take a while. They may not adopt that originally at the onset, because it is such a completely off topic kind of concept for certain cultures to understand, but it really will make the skin much better. So definitely find a way, in a culturally competent way, to explain to your patients that it will make their eczema worse, but they can use a washcloth in the groin and the underarms.
Another question, do you recommend different moisturizers then for different races?
So I'll start, but and Andrew, you can chime in. I typically do use a lot of ceramide-based moisturizers. I do have a large skin of color population. I don't know if I use different ones for different races, but I do tend to use ceramide-based moisturizers for a lot of my patients. So I don't know if I change it differently. It might have more to do with the patient's clinical presentation. For example, if a patient has more ichthyotic changes, then I might want to use something that has some exfoliants like a lactic acid lotion. So I probably do it more based on the clinical presentation than the actual ethnicity.
Yeah, I agree with you, Heather. I think what I'm taking away from your comment is that you basically take an individualized approach. You look at the patient in front of you and come up with a moisturizer recommendation that's best suited for that patient. Part of that decision making, in my opinion, is what we see clinically. How dry is the skin? Is there an ichthyotic component? How scaly is it? And that could push us in the direction of using products that have keratolytic properties like salicylic acid, urea, glycolic acid within their skincare, or cultural preferences for thicker, more petrolatum-based or ointment-based moisturizers for some individuals. So, but you can't really, basically the bottom line is there isn't a one size fits all, and you also can't just generalize and say that most people belong or everyone belonging to one group prefers this while another group prefers the other. I think it's helpful to involve the patient in your decision, describe in layman's terms the different options available as far as consistency, get their feedback too as far as what they would actually prefer using for their skincare. So it's a mixture of patient feedback, their cultural background, and also the clinical, what are you trying to achieve with respect to motion.
And I'll add one more thing to that is the climate, because I am in this very hot, humid climate. So it's hard. People don't want to wear ointment. I use a lot of ointments at night in my atopic dermatitis patients or people with very dry xerotic skin. And a lot of times people will say, I don't want an ointment because it's too sticky. So then I'll say, okay, we'll use it at night and we'll use this during the day. So I think that it's even has to do with where you're practicing, what time of year it is, how humid it is outside. All of those, I think, play a role.
So how do you explain the increase in cholesterol and fatty acids when you use only ceramides, or does the product have a lipids?
It also had the lipids, but the focus is on the ceramides, but it also has those lipids.
Is there evidence regarding the use of topical hyaluronic acid serums and creams containing hyaluronic acid provide additional benefits to the stratum corneum barrier function when used in conjunction with topical ceramides?
Okay, can you repeat that question? I didn't hear it. Say that one more time.
Is there evidence regarding the use of topical hyaluronic acid serums and creams containing hyaluronic acid to provide additional benefits to the stratum corneum barrier function when used in conjunction with topical ceramides?
Okay, so hyaluronic acid is probably one of the hottest topics and ingredients in skincare. Everybody loves it. Everyone has a hyaluronic acid serum. When women walk into clinic with a bag of all of their skincare, there's almost always a hyaluronic acid serum in there. So I think derms have a mixed opinions on hyaluronic acid. Some derms love them. Others feel, like I mentioned, hyaluronic acids can dry out the skin if you live in a dry climate, because they can pull water from the cells. So I do think hyaluronic acids do play a role, but ideally, because they are humectants and absorb lots of water, they should be used with an occlusive or something on top so that you can trap that water in.
What is the best treatments for keloids and scarring in dark skin?
So I'll start. Of course, that's a little bit outside the scope of barrier, but happy to take that question since it's so relevant to skin of color. Beyond the obvious answer of intralesional corticosteroids, I think probably the question has to do with more adjunctive skincare. So silicone-based products, there is evidence for using silicone, either sheets or gels, as an adjunct to intralesional corticosteroid therapy and other standard therapies for keloids. As a standalone, I haven't found them to be very useful, but for adjunctive use and also for maintenance, so after you flatten that keloid with triamcinolone injections, maintaining the flattening of the keloid, I find might be extended by using silicone-based gels or sheets. Heather?
Yeah, I think we practice the same way when it comes to keloids. I do use intralesional triamcinolone typically to treat, but as an adjunct, I sometimes use those steroid tape, a prescription steroid tape that is sometimes helpful. And they do have studies that suggest that silicone tapes and silicone gels might help with the symptoms of keloids. So sometimes I'll give patients those products just because it might help the symptom of itching, burning, and sensitivity. It may not flatten the keloid, but I definitely think it could help with the symptoms. So I do incorporate them for the right patient.
I'm glad you brought up itch, because itch is such an important symptom that we don't talk about much in the context of keloids. But let's face it, our keloid patients almost universally complain of itch. So,
right.
Yeah.
And if we can relieve that, they're so happy. So I think that is, don't underestimate, the symptom. Patients want their keloids flat, don't get me wrong, but they also, if you can relieve the symptoms, I think they're halfway there.
Okay, do you recommend the glycerin soap to use for xerotic skin?
I don't typically recommend a glycerin soap. I think they probably use that for that study, just because it was considered a bland soap. But if patients have xerotic skin, I tend to use cleansers that are hydrating.
And just to piggyback on that, when I think of cleansers that are hydrating, so breaking down the cleanser into the surfactant and then what moisturizing ingredients do they have. So you want to ideally find a cleanser that has gentle surfactants and that also has moisturizing ingredients that will sort of replenish the skin's lipid that has been stripped away by the surfactant. So you want to look for a cleanser that also has some occlusives and humectants in it, together with the surfactant, which does the cleaning work of the cleanser.
What's the difference between fragrance-free and unscented?
Oh, I love this question. I get this a lot. So basically, fragrance-free means there's no added fragrance. That means nothing was added to the product for the goal of changing the scent of the product. Unscented means that there's no, you can't smell it. So when you're formulating products, there's actually a fragrance called unscented. So sometimes, for example, with natural products, they might have a strong natural odor. And if for whatever reason the formulator wants an unscented product, they might add a neutralizing scent to eliminate the natural odor of whatever those ingredients are. So unscented means that there's no scent, but there could be fragrance in there, and people sometimes don't realize that. Whereas fragrance-free means there's no added fragrance, but that doesn't mean there's no scent, because let's say there's an ingredient that has a strong natural scent, if that's the scent of the ingredient, you still may be able to smell the product, but no fragrance was added. So it's an interesting concept that I don't think everyone totally understands. Fragrance-free means there's no added fragrance. Unscented means there's no scent, but there could be fragrance in there.
Do you recommend different moisturizing products for different anatomic areas?
Yeah, I can start there. I do think that, when we think about our patients' concerns, there certainly are various differences as far as their moisturizing needs for the head and neck area versus elbows and knees versus their hands versus their legs, as an example. So yeah, I do end up using, at the very minimum, a different moisturizer for the facial areas versus the body areas. But then within the body, there are these select zones where there are some unique concerns, like the darkening and hyperkeratosis of the elbows and knees, or very dry hands, which would require an even thicker, more effective moisturizer than one that you would use on the face. So yeah, definitely take a look at anatomic locations and considering what's best.
Yeah, I agree. And when it comes to skin of color, that's probably one of the biggest complaints I get from women is darkening on the elbows. And typically it's only one elbow. It's not always, or one elbow is significantly worse than the other elbow. And it's something I see all the time in clinical practice, that lichenified, hyperpigmented elbow. And no one has named it yet, but maybe after this talk someone will. But it's a very, very common complaint. And then for that type of xerosis, I'll even use steroids, because it gets so thick, it's almost like psoriasis, but it's not. It's truly just dry xerotic skin in a darkly pigmented person. And also combine it with maybe a moisturizer that has some keratolytic properties.
Do you have any recommendations for patients with keratosis pilaris or follicular prominence?
Yes, this is a scenario where not only do we want to moisturize the skin, but we do want to leverage keratolytic ingredients like urea or salicylic acid as an example, or ammonium lactate. Combining very moisturizing ingredients with keratolytic ingredients is generally the approach to KP and follicular prominence. Heather, do you have a?
Yeah, I do the same thing. And the only other thing that sometimes patients will like those glycolic washes or some type of wash that helps with KP also, using a loofah. It's a one place, you know, I just talked about how we don't want our patients to use scrubbing devices, this dry xerotic patients, but this is the one case where sometimes patients do see improvement in their skin texture. And as long as it's followed up with a nice moisturizer so that, you know, it's not too abrasive, but it's one of the few times where I do think you can see some improvement with a loofah or something rough to kind of physically exfoliate those KP bumps.
And in very severe cases, this is an instance where I would consider chemical peels as well in the right patient who's not responding adequately just to the things that we've already said. So salicylic acid peels or low concentration glycolic acid peels, helpful adjuncts for the more severe cases.
I have done that. I've actually done a retinoic acid peel, and it worked great for KP. So one other thing to consider.
Do you mix moisturizers with topical steroid, or will you advise 5 to 10 minutes interval in between topical moisturizer and topical drugs? Which one first?
I typically usually I would say tell patients medicine goes first. That's what I tell my patients. So they put their topical steroid first and then the moisturizer on top. And very rarely do I stray from that in my practice. I'm trying to think of a situation where I would mix them. And the only thing is sometimes there are some formulations that are popular with compounding pharmacies where some people will put, for example, a really high potency steroid like clobetasol into an ointment to kind of dilute it a little bit. But I don't typically do that. And typically my everyday practice, steroid first, moisturizer on top. That's what I do.
What do you recommend for patients who have post-inflammatory hyperpigmentation from their atopic dermatitis eczema?
Oh, wow. That's really hard. I tell those patients that we have to treat the eczema first. Anything that I would give you for the hyperpigmentation will make your eczema worse. When their eczema is under control, I have tried with like tiny, tiny baby steps, azelaic acid, mixed with triamcinolone and a really great moisturizer on top, but setting very realistic expectations because almost everything we use to treat hyperpigmentation can make eczema worse.
Yeah, and I have the same mindset, and I have a rule with my patients. I say that if you can still feel any texture change on the surface, then we're not ready yet for any hydroquinone or other bleaching agent. I want that eczema, lesional skin of eczema completely resolved before we start using bleaching agents because of the irritation potential. So if it's still symptomatic or there's texture to it, then not ready.
This is a good one. How do you motivate patients that may not be compliant with recommendations, are exhausted, overwhelmed with chronically relapsing skin conditions causing symptoms like itching?
I don't know, you want to take that one, Andrew?
One more time, Roxanne, if you could repeat that question.
How do you motivate patients that may not be compliant with recommendations or are exhausted, overwhelmed with chronically relapsing skin condition causing symptoms like itching?
Mm-hmm. Yeah, I think that when we invest that extra time in that consultation to really explain why we're doing what we're doing and trying to get the patient's buy-in to whatever our recommendations are, I think that really improves adherence. So there are some things where there's wiggle room. You know, a patient may strongly prefer to use one particular product, which in your professional opinion might not be your #1 choice, but it may be acceptable, and you might compromise there to allow them to do that. But then at the same time, you have them use a prescription product or another product that's very important to the treatment regimen. So it's a give and take, and with time, I think that you can turn most patients around. If you explain why you're doing what you're doing, and also get a little bit of their input into it so that they can buy into the overall plan. Heather?
Yeah, and I totally agree. I talk a lot. You all have noticed that. And I think the more time you spend with the patient, the more they will respond to your treatment regimen. I also, with my parents of kids with atopic, I do a lot of clinical trials. I'm doing a large clinical trial right now on children with atopic, and I always reassure the parents that they didn't do anything wrong, because I do think that parents will blame themselves and, well, I didn't do this, or we went to the beach and that's why, or this happened and that's why. And I always try to explain, because they're frustrated. They're like, why is my child just itching all night? And my son had pretty significant eczema, and it is, a little bit of, it provokes a little bit of guilt, because you feel like, well, what did I do wrong? And so the one thing I really emphasize for parents, and I think this is a good take-home message, tell every parent you didn't do anything wrong. Your child has this condition, it's hereditary, you probably have some atopy in your family, and I'm going to give you the steps to make it better, but it's not your fault. So I think that is a really important concept to communicate to parents. And then for the frustrated just a regular adult patient, it's spending a lot of time. That's when you might spend an extra 15 minutes in the room and say, if you do this and if you're compliant, I promise you will get better. And I tell patients they'll get better. Tell them that. I learned that from my former chairman, Dr. Eaglestein. He always said, tell patients they'll get better. The power of the mind is just as important as what we give them.
One question, timely, is how should skincare be used to counteract some of the COVID issues like maskne?
So I can jump on that. So maskne can be caused by two things. One of the people know just regular acne, and I've definitely noticed that. And we treat that with just regular acne treatments, benzoyl peroxide, salicylic acid prescriptions if we need it. But the other thing that people don't realize is that maskne can be caused by chemicals that are in our masks. So our masks, the masks that we use from the hospital, typically have chemicals, and then some have formaldehyde or different chemicals that can be irritant dermatitis, that can cause an irritant dermatitis. So I think it's first important to distinguish between whether it's true acne that's just being aggravated by wearing a mask versus an irritant dermatitis, which we approach differently with, maybe a topical steroid or an anti-inflammatory, and changing to a white cotton cloth mask.
And I'll just add a couple additional pointers. No makeup on under the mask is something that I advise, and to not forget about your routine skincare prior to putting on your mask. To use a gentle cleanser prior to, and a non-comedogenic moisturizer prior to starting your day and putting on your mask for long periods of time. And then the last thing is mask breaks. To the extent possible, if you can go to a socially distant, physically distant environment, a safe environment, and take your mask off for a few minutes several times a day, that too can help minimize the duration of the occlusion and hence the risk of maskne.
And one last question, are there cleanser recommendations for patients with skin of color or patients with dry, sensitive skin?
Again, as we mentioned earlier, I think a hydrating cleanser is what I typically choose. I mean, I treat a lot of acne. So my patients are typically on, a benzoyl peroxide wash or a salicylic acid wash, but if they can't tolerate it, then I typically use a gentle cleanser. And that's probably because they're on a retinoid and they may be on a BP, a higher concentration prescription BP, benzoyl peroxide. And so I don't want a cleanser that's going to strip the skin. So for me, I'm either using a medicated wash with a specific intention of treating acne, or a hydrating cleanser because I am pretty aggressive with my prescriptions and I don't want to irritate the skin further with a harsh cleanser.
Well, again, thank you so much, Dr. Heather Willery-Lloyd and Dr. Andrew Alexis, for this great session. I'm just showing the slide because people have asked me to show the website where you can also find the recording on cerave.com and rbcconsultants.com. And if we did not get to one of your questions, you can always send a question to info@rbcconsultants.com, and we'll try to get back to you as soon as possible. So thank you so much, everybody, for joining us. Truly appreciate it. And we wish you all a great evening. Bye now.
Bye-bye.
Bye, thank you.